This week on Being Well, we're addressing diabetic foot care with podiatrist Dr. Joseph Borragini of Family Foot Care Center. We'll talk more about why diabetics need to pay special attention to their feet and how to take care of those minor problems before they turn into serious issues. We've got a lot of great information for you coming up, so stay right here. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. AlphaCare, specializing in adult care services that range from those recovering from recent hospitalizations to someone attempting to remain independent while coping with a disability, chronic illness, or age-related infirmity. AlphaCare, compassionate professional home care. Additional funding by Jazzercise of Charleston. Dr. Joseph Borragini joins me today from Family Foot Care Center, and you have an office where?
In Charleston and Effingham.
All right. Well, today we're talking about diabetic foot care. I wanted to ask, how big is your practice? How many diabetics are you treating, or what percentage?
I would honestly say that a majority of our practice is a diabetic population. To say 60–80%, that would be a fair amount.
And in your time in being in a podiatrist, has that gone up over the years?
Actually, it's gone up over the years. The 60–80% is the most current number. I'm going to say that it's probably gone up double that since
Wow.
I've been in practice.
We're going to get into some more statistics a little bit later as the show goes along, but let me just ask, why do diabetics seem to have more problems with their feet than non-diabetics?
Well, the diabetic basically suffers from circulatory problems, neurological problems. They lose sensation to their feet, the inability to heal wounds. And the sugar builds up in the system and creates all kinds of issues with infection and so forth.
So when someone comes into your office, what's the typical thing that you're seeing?
Outside of the common fare that we see, the heel pain, ingrown nails, warts, and things of that nature, the diabetic population that we see is generally speaking coming in for what we would call at-risk foot care. That is the nail and callus trim, which you would think would be not an important thing, but to the diabetic it's very important. We are able to provide palliative care, and then we are able to assess any major problems that are occurring with that patient over time, and eventually we're trying to stave off any complications that might occur. We can identify any deformities that may lead to further problems down the road.
So like basic things, even like trimming your toenails, that can actually become dangerous for a diabetic?
Absolutely. A diabetic who's suffering from loss of sensation to their feet, poor circulation, could inadvertently trim their nail, cause it to bleed, and create an infection. And I've seen that time and time again in my office. So it's really not recommended a diabetic provide any care to themselves regarding foot care.
And is there a big difference between the type 1 and the type 2 diabetes in terms of foot issues?
The type 1 diabetic suffers from an insulin dependency, so they have to have exogenous or external insulin. To not confuse the fact, the type 1 is normally the childhood onset diabetic. The type 2 would be the adult onset diabetic. Normally they're the ones that are taking either exogenous insulin orally or injectable.
Okay. Are they at risk for the same kind of foot issues?
Yes.
Or do you see the same kinds of things?
But unfortunately, the longer you have diabetes, the higher your risk is for mortality.
Okay. Well, let's start back to the beginning.
Sure.
Let's just talk about some daily preventative things that you tell your patients, diabetic patients, and how to best take care of their feet.
Here's a good thing that we tell patients: buy a mirror, put it on the floor, examine your feet that way. You can look actually on the bottom of their feet. And the other thing I always tell them is look out for the scorpions in your shoes. I am not kidding. A diabetic will come in with something that they've gotten into their foot, either because it was in the shoe or they didn't know it was there. So it's important to examine their shoes along with their feet. So it's very important to do the proper hygiene. Cleanliness is very important, making sure you clean between the toes. Also, when you're in the shower or bath, make sure you dry your feet off completely. Any excessive moisture between the toes can create problems such as athlete's foot and so forth.
Okay. What about for women out there who are diabetics? They like to get pedicures and things like that. Are there some risks for diabetics who go out and get pedicures done?
Just as I said with self-care, you should be very careful when you're doing professional care outside of a doctor's office. Make sure that the instruments are clean and sterilized. Very important. The whirlpools have a tendency to sometimes contain bacteria and fungus, and those things should be cleaned out each and every time a person uses them. So you really want to be observant to how that pedicurist is doing their job and how their office is set up.
Okay. Let's talk about footwear. What should diabetics be looking for in terms of shoes for everyday use, and then we'll get into if you want to do some athletic things and exercise.
Well, it's a great question that you asked that, because we provide diabetic shoes to our patients. It's actually through the Medicare system, but other insurances will reimburse for that as well. But the shoe is specifically designed for the diabetic. It's an extra depth shoe.
What is depth? What does that mean?
It means that the shoe is extra depth for the purpose of an extra type of insert that's going to go in the shoe that's going to modify the amount of friction that's occurring on the foot.
Oh, okay.
You can reduce that friction and heat and so forth on the foot, then you can prevent the chance of getting ulceration or breakdown of the skin, callus. Patients that have deformities that are diabetic, such as a bunion or a hammer toe, that's a deformity that can, generally speaking, cause irritation. So you want a high toe box. You want materials that are natural. Stay away from the nylons, anything that doesn't wick away moisture. You want to be careful of those types of things in the shoes that you buy.
Okay, so what about women who want to wear some high heels, or in the summer flip-flops or sandals? Not recommended?
again, even if you're not diabetic, it's important to understand that those are what I would call a special type shoe that you don't need to be wearing daily. I see this all the time. Patients will come in and are continually wearing the flip-flop as a everyday shoe. Women that want to wear the high heel, that's fine, but it's not an everyday type thing. So you just have to be cautious and careful. And as we tell patients, anytime you're buying shoes, buy them at the end of the day. It's when your feet are the most swollen.
That's a
so
good
it's very,
idea.
very important.
So should diabetics be wearing shoes all day? I mean, they obviously have to wear them when they're at work, but what about when they come home? Should they take those shoes off and walk around?
I would definitely take the shoes off, socks as well, examine their feet, but it's important to put something on. I would not necessarily walk barefoot through the house. Again, I'm always fearful of that diabetic that doesn't have the sensation that we would normally expect to have in our feet, and it's important to protect them. So slipper of some kind. They actually make a diabetic slipper that's extra depth and has an insert. So you really have to be cautious of the types of shoes you wear and when you wear them.
Okay. So have you had cases where something like a simple blister or a wart on a diabetic foot has escalated into something much worse?
Yes, I have. And unfortunately, it's a situation where the diabetic has left it unattended, has not sought care, and creates a problem.
Okay.
And that problem can turn into an ulceration or opening in the bottom of the foot.
Okay, so really some of those simple things for the rest of us can really, for diabetics, lead to much worse problems.
Correct.
So what are some of the early signs that someone should, if they're watching this show and they go get their mirror and they look at their foot and like, I see something on the bottom of my foot. When should they see their doctor or their podiatrist?
If there's a area of redness or irritation, callus, anywhere on the bottom of their foot, get it examined. Skin condition, abnormally cracked or dried skin on the bottom of their feet. Also look at their nails, toenails, particularly fungus type toenails, thickened fungus nails. Those are really important to make sure that you're doing everything you can to prevent that fungal condition from spreading.
Okay, so something you may think, it's just dry skin, it's winter, not a big deal.
Eczema could be the problem.
Okay, so how does it usually work if someone does find that they have something on their foot? Do they see their primary care physician or
provider first and then they get referred to you?
Some
or?
patients directly come to me or a podiatrist. Others may see their primary doctor and they may refer to that podiatrist. So that's usually how the patient traffic pattern flows. It's been that way for years, and we just tell patients, if you're seeing your primary doctor, tell them that we're seeing you.
Okay.
If not, we communicate through letter.
Okay, that's good to know. So we talked a little bit about everyday shoes. We all know it's good for all of us to exercise, even diabetics. What kind of shoes do they need when maybe they're going to do a walking program or do some weightlifting or something? What kind of shoes?
And again, without using brand names, again, we want to make sure that that shoe is properly fitted. A lot of times patients will go into the shoe store and say, oh, I'm just a size 7 or a size 8 or whatever. But make sure you get sized. Mm-hmm. That's the first thing. The next thing you want to make sure is that shoe deep enough to accommodate any sort of insert that you put in the shoe? Is the toe box high enough to accommodate any deformities around the toes?
Okay,
Things
so toe box, that's
the height. The height of the
okay.
front of the shoe.
Okay, because you don't want your toes, the top of the
Right.
shoe pressing down in your
Right.
toes.
And what I found was interesting is that the slip-on type shoe that a lot of patients like to wear are wearing them too big.
Okay.
And so that slippage can cause some friction problems.
Okay, so why does the friction cause problems?
That's heat. That heat
Okay.
can create skin breakdown, eventually a blister and a possible ulcer.
So it's just start small and
this
adds
escalates.
up.
Absolutely.
What do you recommend in terms of exercise activities that are good for diabetics?
Not only to the diabetic, but to most patients, I recommend walking.
Okay.
All right, and running is fine, but if you're not doing it as a everyday type thing, I would probably stay away from it. Walking actually can make you be very healthy. And the recommendation, and people think it's a long way, but a good mile walk a day is very, very good to do.
So your diabetic patients that exercise, are you finding them better off health-wise?
Absolutely, yes.
So good recommendation.
Yeah, absolutely.
Okay. I looked up this term called neuropathy, and that's associated with diabetes. What is that?
Again, I think we kind of alluded to what neuropathy is. Neuropathy is actually the loss of sensation to the feet or abnormal sensations to the feet.
Okay.
It's actually a breakdown of the insulation around the nerve that allows that nerve to operate the way it should. That is, the speed of that signal traveling from the brain from the foot back to the brain is slowed down.
Okay.
Or can get lost. Mm-hmm. And so that insulation is kind of like the insulation around a wire.
Okay.
Think of it as the insulation around a wire prevents the heat from building up in the wire. Mm-hmm. Well, the same thing happens with a nerve. As that insulation starts to unravel, as that sugar starts to break down that insulation, the nerve loses its ability to function properly and provide the sensations back to your brain to let you know what's going on.
Okay. Does that neuropathy only happen in diabetics, or does it happen as people age?
It can happen as you age, but there's certain diseases that are relative for that type of condition. Years ago, syphilis, alcoholism was the big thing. B deficiency, vitamin B deficiency. Mm-hmm. But diabetic neuropathy is probably the biggest thing that we see. The biggest thing that we see is the pain that's associated with it.
Okay, which is if the nerve is sort of, why do you get pain if the nerves are not?
The pain is related to the fact that the nerve is sending a signal that the brain doesn't know what to do with.
Okay.
And there's a substance that's released. It's actually called substance P. And it's released and it causes pain. And it's uncontrollable pain.
Okay.
It's almost like you're injured type of pain.
Okay, so how do your patients describe that pain?
As shooting, stabbing, tingling, sharp knives type sensation.
In the bottom?
In the bottom of their feet.
Okay.
Sometimes it can affect the whole foot up the leg.
Okay, so do you see that in later stage diabetics, or can it happen?
I see it more in the diabetic that's out of control with their sugar. That is, they're not managing their diet properly, they're not taking their medications when they should, they're not checking their diabetes the way they should by seeing a doctor. It's the diabetic that's just not where they need to be with control and staying on top of their condition.
Okay.
And it has to do with the denial factor. If you have a condition of that chronicity, you start to say, I don't have it.
Do you find that You have people like
Yes,
that?
absolutely.
And why do you think that
It's,
there's
it's human nature. You have a condition, you ignore it.
Uh-huh.
You think it'll just go away. Unfortunately, diabetes doesn't go away.
No, it doesn't.
No.
Because one of the things we talked about can happen, it starts off with this small spot or
Right.
whatever. What happens next?
As-
Kind of
as-
walk us through the
Well,
stages.
as the blister breaks down, if you don't get a ulcer, you eventually will if you're not treated, and that ulcer could turn into an infection and possible amputation.
Okay, so what's the likelihood if someone has this untreated ulcer that they're going to seek?
Infection can lead to hospitalization. Hospitalization requires long-term antibiotics. Wound care. That wound care requires usually debridement. That's a big word, but that's actually cleaning up the wound, allowing it to try to heal. Lots of money is spent to do that. So it's a situation where they're going to do everything they can in medicine and as well as our field to save the limb and the foot. As I tell patients, if you have a diabetic ulcer that is a hole or an opening in your foot, your diabetes has gone malignant, and statistics show that you have a greater risk of death. If you're a female, if you had breast cancer, you have a less chance of dying. If you have a male and you have prostate cancer, you have less chance of dying if that diabetic ulcer occurs.
Wow. Just from something on the
Yeah.
bottom of your
Yeah.
foot. So what kind of treatment do you provide for foot ulcers and for wound care and things like that?
Wound care, we're generally seeing them on a weekly basis, providing removal of the bad tissue, trying to provide topical remedies to allow that to heal, taking the patient off weight bearing, that's the gold standard, try to get their foot off the ground. Sometimes we'll cast them, put them in a total contact type cast. Diabetic shoes is a preventative measure. Eventually we want to get that to heal. Sometimes a surgery has to be done to take away any of the deformity that's in the foot. And conditions can occur where there's actually breakdown of the foot, that is completely collapsed foot. It's called a Charcot foot. And that unfortunately is a severe case. But we do everything we can in a preventative way to keep that patient having the digit, the limb, and that part of their body to stay on them as long as possible.
So what would you say if someone has some kind of ulcer, at what stage, I don't know if you can identify, what stage could it be at that you could actually cure it and take care of it and have it go away?
It's usually the earlier the better.
Okay.
The faster they come in with it, the better the chance of its healing. As tissues start to be exposed, and not to alarm your viewers, but if you start to see any fatty tissue or muscle or actually bone exposed, that becomes a severe, serious problem.
Yeah, because that, I can't imagine that
Yeah.
gets infected,
Yeah.
and we're talking about some serious.
And they catch every bug there is,
Okay.
every bacteria.
So
could
if it just looks at this stage
Yeah.
like maybe a red spot or a blister, that's
very
still
important to
pretty-
get it looked at.
Okay.
Yeah.
So do you recommend that diabetics have their own? It seems like the feet are one of the first things, one of the biggest problems that they have a podiatrist or a regular person that they can see.
They should be seen by a podiatrist minimum of every 6 months.
Okay.
Minimum. That's twice a year. And we see the actual geriatric patient probably 4 or 5 times a year for foot care in general. But it's important that you minimally see that podiatrist every 6 months. Just as well as you take care of your eyes as a diabetic, you should take care of your feet.
Yeah, I've heard diabetics need to have their eyes checked more than non-diabetics too, because that's the other area
Yeah.
that seems to be problematic. Are there just some other things that you'd like to tell people out there as far as their foot care if they're diabetic? Give us sort of a list of what Dr. Borghini says.
Again, to kind of review, it's important that you're examining your feet on a daily basis. It's important that you have proper shoe gear. Don't keep wearing the same shoe over and over and over. Just as a runner would replace a shoe every 300 miles, I would replace that shoe that you're wearing probably every 3 to 6 months.
Okay.
And it's important that you're seeing us, that is the podiatric profession, to have that routine examination. Even if it's just a look-see, doesn't actually have to be a hands-on treatment. It's important that they do that. Foot care in general is an important thing regarding nail and callus trimming. So anything that you have suspect about, get it looked at, whether it be by myself, a podiatrist in the community, or your medical doctor, and get it looked at.
Okay.
Very important.
All right. Well, we're all out of time. I want to thank you for stopping by the show today.
I thank you very
and
much.
I love your jacket.
Thank
by
you.
the way.
Thank you. Merry Christmas.
A diagnosis of rheumatoid arthritis, or RA, can be pretty scary. That's because the chronic condition can cause painful damage to your joints. Vivian Williams introduces us to doctors at Mayo Clinic who say an early diagnosis and an aggressive approach to treatment may help more people get their RA under better control.
At first, Pam Sinecrope thought her knee pain was from overdoing it on the tennis court.
I thought, oh, it's just, a typical sports injury.
Then she hurt her other knee.
And then I injured my left shoulder.
Then pain and stiffness in her wrist and fingers that would come and go. Pam was diagnosed with rheumatoid arthritis.
So, yeah, I was scared. I thought my life was basically over.
So what is rheumatoid arthritis? So this is an autoimmune inflammatory disease. And when we say autoimmune, it's really the immune system attacking oneself.
Dr. John Davis says the joint capsule has a lining of tissue called the synovium. The synovium makes fluid that keeps the joint lubricated. When you have rheumatoid arthritis, your immune system sends antibodies to the synovium and causes inflammation. This causes pain and joint damage, especially in small joints in fingers and hands, but it can affect any joint.
So when you find out, you just have to just let go and express your feelings, cry, do whatever you need to do, let the emotions out, and then get into problem-solving mode.
Well, I call it my own personal yogurt.
For Pam, that means controlling what she can. She eats a very healthy diet, researches to learn about RA, and she began treatment fast.
The current mantra is so-called treat to target. So we want to initiate a treatment. We would then want to, in a fairly short period of time, measure if it's working and doing something or not. And if not, to begin making changes in a sort of an assertive fashion over time.
I'm on methotrexate and low-dose prednisone.
Prednisone taken short-term to calm inflammation and methotrexate long-term to keep the RA in control. If those treatments are not enough, they can be combined with what are called biologic treatments.
That the majority of people with our current techniques and with using combination of medications together get good control and can get back to their usual functions the majority of the time.
Dr. Davis says patients like Pam may soon benefit from research at Mayo Clinic that explores new therapies and how a person's genes might tell doctors which medications work best. They're searching for new ways to give each individual patient exactly the care they need. Pam knows RA is a lifelong condition. Flare-ups may happen, and she has to pace herself sometimes, but treatment is working.
I feel great. I feel better than I've felt in probably 10 years.
For the Mayo Clinic News Network, I'm Vivian Williams.
There is no cure for RA, and some patients continue to struggle with significant symptoms. But with aggressive and prompt treatment, Dr. Davis says most RA patients can get control of the disease. Well, thank you for joining us this week on Being Well. Look for past and present episodes on our YouTube channel. That's youtube.com/WEIU. We'll see you next time.
Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. AlphaCare, specializing in adult care services that range from those recovering from recent hospitalizations to someone attempting to remain independent while coping with a disability, chronic illness, or age-related infirmity. AlphaCare, compassionate professional home care. Additional funding by Jazzercise of Charleston.